Well, we're going to talk about a subject today that you're going to be surprised that two grown men are going to talk about, and that's a lady's private parts. Now, normally you would say, wait a minute, we want to hear a woman's side when you're going to be talking about something like this. Well, actually, if you're going to talk about a woman's private parts and medical issues, wouldn't you want to hear from a pro, even if it is a guy? Yeah, it is a guy. It's Dr. Magdi Malad. He is Chief of Gynecology and Gynecological Surgery at Northwestern Memorial Hospital. And today we're going to talk to the doctor about something a lot of people really don't talk about, and that's hysterectomies. You know, every year here in the United States, more than 500,000 women have hysterectomies. It's the second most common surgery for American women, right behind C-sections, cesarean sections. So we thought it'd be a good idea to go ahead and check in with the doctor. He's up with Northwestern Memorial Hospital. We've had them on before. It is a great facility, also a great teaching facility in the heart of Chicago. Dr. Malad, good morning. Good to talk to you this morning. I know it sounded kind of goofy, two guys talking about lady parts, but you are the expert when it comes to this. I've read your background. I know your resume. And what's great about what you guys do up at Northwestern is you're always getting into research and finding alternatives to therapies. And that's really what I kind of wanted to get to, because some women really are afraid of the hysterectomy. It sounds like a torture horror show for these women to go through, and they're afraid they're going to be off work for months. They're going to be in a lot of pain, and unfortunately, in some cases, they are. So first of all, let's talk about the hysterectomy, and then I want to get into alternative treatments. Doctor, good morning.
Good morning. Thanks for having me on.
Yeah, great to hear from you this morning. To help the uneducated and buffoonish men like myself who aren't really familiar with hysterectomies, because obviously this is something I'm not going to have to face in my future, but a majority of American women will. What is the hysterectomy basically in a nutshell?
Sure, yeah. So hysterectomy is defined as removing the uterus. And there's sort of a partial hysterectomy, which is where we remove the uterus, leave the cervix, which is the opening of the uterus down in the vagina, or a total hysterectomy, where the cervix and the uterus are removed. Whether the hysterectomy is done as a partial or a total, we oftentimes remove the tubes, the fallopian tubes. We think that removing the fallopian tubes at hysterectomy lower the risk of ovarian cancer in the future, which is kind of a crazy idea that the tubes somehow put the ovaries at risk for cancer in the future. And in general, we leave the ovaries. So that's a big change from when I trained. When I trained, ovaries always came out. But we know now that by leaving the ovaries, we can improve the quality of life in women. By taking them out, it significantly reduces their quality of life, not just vaginal dryness or hot flashes and night sweats, but also potentially long-term issues like bone loss, heart disease, maybe colon cancer, maybe increase the risk of Parkinson's. So we leave the ovaries whenever we possibly can if hysterectomy is ultimately needed.
You know, you brought up a word there, a couple of them that scared me, and they are ovarian cancer. I lost a very dear friend of mine several years ago to ovarian cancer, and you're well aware of that horrible disease. And what caught her off guard was she was already in the late stage when it was diagnosed, and her doctor and oncologist both said, unfortunately, it's hard to detect ovarian cancer in the earlier stages. Is that reasons why we're seeing more and more women at a younger age getting hysterectomies?
No. Ovarian cancer, affects about 1% of the population, so it's a relatively common condition. It's still difficult to detect. Ultrasound has not been proven to be a good screening test. Blood tests have not been shown to be a good screening test. Pelvic exam has not been shown to be a good screening test. So we really still don't have a great way to screen for ovarian cancer. It's embarrassing because, 25 years ago, there were sort of cancer screening programs being opened up and all kinds of great ideas that were being offered up. And that still has not been borne out, screening for ovarian cancer. Having said that, it is a relatively, leaving the ovaries in a woman who's having surgery significantly improves their quality of life. And so we think that the risks of leaving them in outweigh the benefits in an average risk woman. In a woman who's at high risk, it's different. In a woman who's prone to ovarian cancer, obviously we take those ovaries out early. it doesn't actually eliminate the risk of ovarian cancer, but it significantly lowers the risk by taking the ovaries out. I know it sounds kind of crazy.
No, absolutely. Yeah. It does make sense. Now, since we're talking about the ovarian cancer, and it is hard to detect, I'm well aware of that. Just decades ago, we started making some really decent strides with breast cancer, but many women were still going out and getting radical mastectomy at a very young age because of a family history of breast cancer. Now, when it comes to ovarian cancer, should we be looking at our family history? Should we be talking to our moms, our aunts, and our grandmothers and finding out if this has been a problem in the family and at what age were our relatives diagnosed with ovarian cancer before we even go rushing to get a hysterectomy?
Yeah, no, 100%. Yeah, 100%. Family history is critical, and that should be asked at every visit. I think for every physician, like every physician interacting with a patient should be asking about the family history of cancer. And if there's a history of ovarian cancer in a premenopausal woman, that is a risk factor for ovarian cancer for that individual. So if that's the case, if there's any family history of ovarian cancer, breast cancer, prostate cancer, all those cancers, that patient should be referred to genetic counseling, and as a result, sort of be worked up, and then that might promote some screening for genetically connected ovarian cancers. Yeah.
But what are some? Yeah, go ahead, doctor.
I was just going to say that more commonly, though, hysterectomies are not being done for ovarian cancer. More commonly, hysterectomies are being done for women that have chronic pelvic pain or bleeding, pressure symptoms, fibroids, endometriosis, adenomyosis. So these non-cancerous conditions, that's by far the most common reason why to do a hysterectomy. And I think the take-home point that I'm hoping to make is just that should be the last resort. In that woman, it should be the last resort. There are many other options: non-hormonal, hormonal, IUDs, ablations, embolization. There's a long list of options for patients before they get to the ultimate, option, which is hysterectomy.
Well, how would you, as a doctor at Northwestern Memorial Hospital, sit down and talk to a patient who's come to you and gotten a referral from her own doctor? And I know you get patients from right here in the Tampa Bay area that actually fly up to your hospital specifically to see you and to visit Northwestern Memorial Hospital. Once that patient comes up, they're off the flight, they're in downtown Chicago at the hospital, they're talking to you, and now you've got to go in, look at her charts, her blood work, and start your own diagnosis. What can this patient expect when they walk into your office, doctor?
Well, we've tried to do most of the work up front. So in a patient who's flying in from elsewhere or locally, we have, when they make an appointment, we call them back and we have them get their imaging. We always bring the actual images because the reports are often misleading. We have an ultrasound done beforehand. We oftentimes have an MRI before they come to our office, and that MRI is uploaded so that I can actually show the patient their own images during the visit. We also will design the visit so that it's sort of like a one-stop shopping, so that when they come in, they often will be seen by multiple providers, not just a gynecologist, but by a physical medicine doctor, by a physical therapist, by an interventional radiologist, by different providers offering different perspectives on the same condition. And so that when they leave the office, after that one set of visits, they already have a good sense of like what our collective opinion is, whether it's a single therapy or multiple therapies being used in concert. And then they can take that home and sort of think about it and maybe implement it at their local site, whether it's physical therapy or whatever it is that we've recommended. So we try and make it like a single visit to be able to answer all those questions in a multidisciplinary way, which I think is quite unique. And it really speaks to like the priority of women's health. Not only do we have a women's hospital, the largest women's hospital in the country actually, but we also have these priorities for women's health services, including non-obstetrical, right? Gynecologic care.
Well, I think that's awesome and really exciting news that I'm actually talking to a doctor who would prefer not to do surgery, and let's try some other options and routes before we get there. But unfortunately, some of these alternative options are not going to work for everybody. And then they're going to have to go and have the hysterectomy. Let's go the next step then. And how are you going to talk to the patient about that? Because as we mentioned earlier, a lot of men and women get boo-booed out about going under the knife.
Yeah, no, for sure. Again, I think the key is prioritizing the patient's wishes and concerns. So, for example, if a patient says, I'm deathly afraid of going under a general anesthetic, then we'll do the surgery under a spinal or an epidural. We'll do it while they're awake. If a patient says, I really want to avoid incisions that are visible, then we'll do an incision that's not visible, whether it's a vaginal incision, it's completely hidden, obviously, or under the sort of in the hairline kind of a thing, in the like a bikini cut sort of a thing. If a patient says, I really want to get back to work sooner, then we'll offer up a scope surgery, a laparoscopy, maybe robotically assisted, maybe not. So it's all about the patient's priorities. If the patient says, I really want to keep my cervix, I just feel like there's nothing wrong with it. I've never had an abnormal pap smear. I just want to keep it. Then we'll, as long as it's reasonable, we'll offer that up. So the key is, again, letting the patient and her wishes and concerns be the number one thing that drives therapies, as long as it's reasonable.
Doctor, I know, and we mentioned earlier about, was saying a lot of women were going out and getting radical mastectomies after hearing scares of breast cancer in the family, and we have females that hear the same thing with ovarian cancer. And anytime, again, we go in and go talk to a doctor when cancer is a possibility, we are pretty freaked out. You mentioned the staff of experts up at Northwestern that will meet with the patient, including physical therapists, you, other doctors. Have we talked about maybe even having counseling for these women? Because there are some women that will go through depression after a surgery like a mastectomy or even a hysterectomy. I know there's been some cases in Psychology Today of some kind of depression after a surgery like that. Do we involve counselors at all?
We do. We have in-house counselors right in our office. So we have two therapists right in our office, and we can absolutely include that as part of the discussion. In patients that have gone down that road, as you kind of suggested, they've already tried virtually everything, and they're facing the decision about a hysterectomy and sort of closing the door from a fertility perspective. Yeah, that's absolutely part of the discussion, is have them meet with a psychologist or a therapist, really explore, is this something that they really are 100% convinced they want to do before undergoing surgery. Absolutely, that's part of it.
Absolutely, great answer, and that's what I wanted to hear. How long is recovery time? I guess to each his own, the patient, each according to their gifts as to how long it's going to take to recover?
Yeah, I mean, 90% of patients are going home same day after hysterectomy. If we do it in a minimally invasive way, whether it's laparoscopic or vaginal, those patients are going home same day. Typically, they're back to they can work at a desk, for example, really whenever they feel up to it. So it might be a week, might be 2 weeks. We do restrict intimacy for 6 to 8 weeks, depending on how things are healing, just so we don't weaken the top of the vagina and put them at risk for like a hernia or something like that. So we'll always do that check just before they're sort of cleared for all normal activities. But short of intercourse or sort of core exercises, really the rest of it is right away. Stairs, showering, walking, all those things, regular diet, right away.
Wow. And I know doctors, rightfully so, with the opioid addiction, are cutting back, trying to prescribe pain medication, but in some cases, a pain management program may have to put into place, wouldn't they?
That's a great question. Yeah. So about 2 years ago, we implemented a program to avoid opioids, and yeah, I'm amazed that it actually works. I hate to admit that, because I was trained in the days where you'd give dozens and dozens of narcotics. I didn't want my patients to be in pain. I've never had that kind of a pain. I would never want anybody to have that kind of pain. So I thought giving narcotics was the right thing to do, and now I realize it really isn't the right thing to do. And surprisingly, if you sort of create a protocol of Tylenol, Motrin, and then if that fails, using very small amounts of other medications in a sparing way actually works. And we not only have we implemented that for our major surgeries like hysterectomies, but it's also being used in other big surgeries, like, for example, colon cancer. I mean, imagine a man or a woman undergoing a colon cancer surgery uses the same protocol and is able to avoid narcotics. So the number of pills I'm prescribing nowadays and patients are using is like less than 5 narcotics in 6 weeks. I mean, it's just amazing how it's changed.
Wow, that's good to hear, Doctor. And of course, your website, we've given it out before, nm.org. If you're looking for Dr. Malad, his website, where his specialty, where he is the chief of gynecology, is migs.nm.org. That again is migsnm.org. Doctor, thank you so much for joining us this morning. Great information.
Thank you for having me.